Good afternoon and welcome to the ROHDEO webinar entitled Access to Dental Care in Texas, New Analysis from the Health Policy Institute. I'm David Capelli, the ROHDEO Director, and we want to thank you for joining us today. So we thought we'd start by giving a little background for those of you who may not be familiar with ROHDEO. So ROHDEO is the repository of oral health data for evaluation and outcomes, and is a statewide database of basic screening survey, oral health indicators, access to care information, and demographic data. Programs across Texas contribute data annually. Each year, the data are synthesized and published on the ROHDEO website for public access. ROHDEO is a partnership between UT Health San Antonio School of Dentistry and the Department of State Health Services Oral Health Program. And ROHDEO is supported by funding from the Health Resources and Services Administration. So this webinar series brings dental public health information and initiatives to both ROHDEO users and contributors, as well as our national partners who are interested in learning more about the oral health of Texas. So you can learn more about ROHDEO by visiting the website at www.rohdeo.org. So before we start, I wanted to review a few housekeeping details with you. This webinar will last between 30 and 45 minutes, after which Dr. Vujicic will answer questions. If you have a question, please type it in the question box. If typing in the chat or question, please make sure that you are typing to the entire audience or sending to all. At the conclusion of his presentation, Dr. Vujicic will read and answer the questions. If he doesn't have time to answer your question, or if you have a follow-up question for him, please contact Dr. Vujicic via email or visit the ROHDEO website, and we'll be happy to connect you with the speaker. This webinar is being recorded and will be made available for review later on the ROHDEO website. You can review any previous webinars on the ROHDEO website under the Resources tab, and we encourage you to do so. As a reminder, if you have not registered your program and submitted your data to ROHDEO, there is still time. If your program's data is entered into ROHDEO before December 1, you will be entered for a chance to win one registration sponsorship to the National Oral Health Conference, or one of 3 registration sponsorships for the AIDPH Annual Colloquium. So the American Institute of Dental Public Health is hosting a colloquium in January on precision oral health. If you need help submitting your data, please email us at rohdeo@uthcsa.edu, and we'll be happy to assist you. If you're interested in learning more about the AIDPH Colloquium on Precision Public Health, please visit www.aidph.org and click on the Colloquium tab. Also, please feel free to email me if you have any questions. The webinar today focuses on newly analyzed Medicaid data from Texas. Dr. Marco Vujicic, the American Dental Association's Health Policy Institute Innovative Analysis measuring geographic access to dental care providers in Texas. So before we begin, let me introduce to you Dr. Marco Vujicic. He currently serves as the Chief Economist and Vice President of the Health Policy Institute at the American Dental Association. His previous positions include the World Bank in Washington, D.C., and the World Health Organization. Both roles focused on using health data for policy development and implementation. Dr. Vujicic authored the book Working in Health and has extensive publications in many peer-reviewed journals. He continues to be prolific in his role at the ADA Health Policy Institute. I think many of you know Dr. Vujicic's national reputation and stature. So with that, Dr. Vujicic, thank you so much for your time and contribution to the ROHDEO webinar series. We look forward to your presentation.
Great, thank you, David. And let me just say again, thanks for hosting and inviting me. to give this webinar. It's always a pleasure, David, to work with you and your team. And it's always nice to be able to deep dive into a particular state, especially one like Texas that's doing so many innovative things. So let's get started. As David mentioned, I head up the Health Policy Institute. This is a group housed within the American Dental Association that focuses on health services research. Here are just a few screenshots of some of our scholarly publications. If you recognize the journals, you'll notice these are broad health policy journals. We try increasingly to target the non-dental world with our research because we feel that's where a lot of the impact lies. This is also just a few recent citations in the popular press of articles where my group's research has been cited, which is always encouraging. Today, basically, we're going to focus on two main goals. One is to, I just want to start with just a quick bit of background, looking at the latest data on dental care use in Texas, as well as some data on the dentist workforce. And you'll see this first part is basically constrained by data. There may be a lot more specific Texas focused research that you all know and I don't. I'm just pulling data that we have for all 50 states and just to show some highlights. And then we'll get into the main part of the webinar today, which is reviewing new analysis, examining geographic access to dental care in Texas for the population as a whole, as well as for the subset of publicly insured children who are enrolled in Medicaid and CHIP. So let's get going on the first part. These are the latest CMS 416 data that came out, I believe, about a month ago, the 2016 data. What we're showing here is just the percent of Medicaid enrolled children who had any dental visit in the past 12 months. And what we're charting is Texas in blue and the national average in orange. And again, you see here the steady increase in the orange line. That break in 2010 is not really something that's a big relationship change. It's a data quirk. But basically, the U.S. is seeing a pretty steady upward trend in the percent of Medicaid children who visit a dentist. Texas is in blue. You see there it's consistently above average on this measure. You see a huge ramp up in 2007 to 2011. And then you see some downward. I don't know if that's noise or if it's real. But the last one is basically 69.2% of Medicaid enrolled children had a dental visit in 2016 in Texas. Racking and stacking where Texas is relative to other states. There are two states for which the 2016 data are still not in, the Dakotas. But this is really important. Texas, not basically, it does have the highest rate of dental care use among Medicaid enrolled children, according to the latest 416 data. Switching gears to the privately insured children. And again, I'm just showing you this because this is where at least my group has credible data that's comparable across all 50 states. There may be more accurate data on this for Texas, but if it's not available for all 50 states, chances are we don't house it. These are data based on a large multi-payer claims database. So we're looking at children enrolled in private dental insurance, and we're asking the same question. What percent had a dental visit in the last year? And again, Texas is in blue and the U.S. average in orange. Both lines going up, so positive trends. But on this measure, Texas is a bit lower than the national average. So when you put this together, What we're doing here is we're taking the latest data for which we have publicly insured and privately insured children. That's 2015. And we are graphing the dental care use rate for publicly insured children, which is the orange dot. And then we are graphing the dental care use rate for privately insured children, which is the blue dot. And then we're ranking or ordering states from left to right according to the size of that gap. In other words, states on the right have a really big difference in dental care use between publicly and privately insured children. The states on the left side of this plot have a relatively small gap in terms of dental care use between publicly and privately insured children. Again, this is just putting publicly insured children against an alternative benchmark. There's a lot of normative targets out there. Every child visiting the dentist twice a year, children starting to see the dentist at age 1 or eruption of teeth. As economists, we like to maybe look at alternative benchmarks. So privately insured kids you can think of as having pretty good coverage in terms of what's covered, pretty good access to dentists in terms of network sizes, etc. So it's just an alternative benchmark. And I think the key thing here is, again, there are 2 states on the left, Hawaii and Texas, that have, I guess, what you'd call a reverse gap, meaning that the likelihood that a child visits the dentist is higher if you're in Medicaid or CHIP than if you have private dental insurance. We don't have similar data for adults, so now we're going to move away from children. It would be nice to have the equivalent Medicaid enrolled adult dental care use rates like the 416 data for children. We don't have that. The BRFFS data, in my view, has a lot of methodological shortcomings. And so what I'm just going to show you is we're going to focus on adults, and this is out of a large study we did 2 years ago, released in 2015, where we had a 50,000 sample of adults across the U.S. Long story short, we have state-level data on what we call oral health and well-being. So here are some results for Texas. This first plot is just the overall condition of mouth and teeth. This is all self-reported. And basically what you see here is this sharp income gradient, meaning that low-income adults in Texas are far, far, far more likely to report poor oral health, according to this measure, what is the overall condition of your mouth and teeth, compared to high-income adults. This is something we see in most states. Let me just get this going here. Okay. The other thing we ask is if you had not visited the dentist within the past year, what were your main reasons, and kind of tick all that apply. And again, these are data specific to Texas. This is the real richness of this data set. So as you see here, these are the top reasons adults are reporting for not visiting the dentist. Cost is number 1 by far. No original teeth is number 2. Trouble finding a dentist is number 3. Afraid of the dentist is number 4, etc., etc. And remember, this is only among those that had not had a dental visit within the past 12 months. When you look at this breakdown by income, which is again a nice thing about these results, we're looking now at low-income, middle-income, and high-income adults in Texas. What they're reporting is their top barriers. You see here across the spectrum, this trouble finding a dentist seems to be an issue. So cost remains number 1 by far. And then if you go to the left side, low-income adults, the next reason is trouble finding a dentist. If you go all the way to the right, right after cost, the next reason is still trouble finding a dentist. among the high-income adults. So low, middle, high refers to your income level, and then these reasons basically are racked and stacked. Just an important thing here, this is finding a dentist that accepts your insurance or accepts your coverage. That's how the question was worded. Anyway, it seems here that low-income adults seem to be having trouble finding a dentist as an issue. So let's look now a little bit at the supply of dentists. This is just the number of practicing dentists per capita. I don't want to spend too much time on this chart, just to show you Texas is slightly below average here, and I guess would be roughly, let's say, in the left third or in the bottom third, roughly, of states in terms of the aggregate supply of dentists. You are seeing big increases. This is a decade's worth of data from 2005 to 2015. We're looking at the change in the number of practicing dentists per capita. So you are on the low side when you look at the last data, but you certainly are on perhaps the highest or second highest rate of increase in terms of the number of practicing dentists per capita. So you're probably in a few years going to be out of that bottom third and into the middle third. So that's kind of an important thing to look at. Big growth in the supply of dentists in Texas. We also did workforce projections in 10 states. Texas was one of them. Again, I'll put the website up at the end. I don't want to go into all the details. We did a webinar on this a few months ago. I'm pretty comfortable predicting you're going to see a rising supply of dentists, pretty sharp rise in the supply of dentists in Texas through 2035. And basically, even after adjusting for age and gender mix, which will change, which affects hours, even the full-time equivalent numbers are predicted to rise steadily according to our projections. Again, you can look at all the detailed methodology if you're interested on our website. Last thing, we do look at the percent of dentists that participate in Medicaid or CHIP. This is defined as the number of dentists who have enrolled to be Medicaid or CHIP providers according to the InsureKidsNow database that CMS runs. So it's a very low bar. It's just basically, have you filled out the paperwork? Have you enrolled to be a provider? Nothing to do with accepting new patients or how many patients you're seeing or what time of day. Unfortunately, no access to data of that kind that we have. But anyway, if you're interested in looking where Texas is here on the left, about 48% of, this is general dentists and pediatric dentists. So 48% of those dentists have enrolled to be Medicaid or CHIP providers. That's slightly above the national average of 38%. We actually have just updated these numbers this week, so look for those on our website. Not a lot of changes year to year. Okay, so let me get into kind of prepping why we did the analysis. I'm going to walk you through in terms of the geographic access, right? So on the x-axis, basically we're gonna plot states in this plot, and on the x-axis we are going to look at the supply of Medicaid or CHIP providers. And in this one, we're defining it as the number of enrolled Medicaid or CHIP dentists per 1,000 Medicaid or CHIP child enrollees. So we're not doing it per capita. We're not doing it as a share of the dentist population. We're doing it in, to me, a much more meaningful way. How many Medicaid or CHIP dentists are there per Medicaid or CHIP child? That's what the x-axis is graphing. And then the y-axis is graphing dental care use among Medicaid or CHIP children. That's basically the 416 data. And of course, what are we expecting to see, right? We're expecting to see the more Medicaid or CHIP providers you have per Medicaid or CHIP child, the higher dental care use is going to be. So we're going to see a nice smooth line when we plot states into this, and that smooth line looks something like this. Not a smooth line at all. You see all sorts of noise here. So Texas is highlighted there. I just showed you it as the highest dental care use rate among Medicaid or CHIP children. it has nowhere near the highest number of Medicaid or CHIP dentists per Medicaid or CHIP child. Those are states on the right, like Utah, Iowa, Pennsylvania, Wyoming. So we looked at this, and HPSA has measures of shortages, and when you look at a plot like this, you ask questions like, well, why is Texas up there where it is, and why is Wisconsin down here, right? So why does Texas have, double the dental care use rate among Medicaid kids as Wisconsin, but roughly the same supply of Medicaid providers measured relative to the number of Medicaid children? So it could be a lot of things, right? It could be data errors. It could be that participating providers are participating in name only. In other words, Wisconsin dentists are enrolled, but severely limiting volume of patients, let's say. It could be the dentists in Wisconsin who are participating are in quote-unquote the wrong locations, whereas in Texas they are the right locations. And by that we mean, like, in high poverty areas, close to the Medicaid population, etc. So that motivated us to take a new look at geographic access, and basically we released these what I'm showing you for Texas is available for every state. We've put an enormous amount of effort in this. It's a huge data exercise. If you're interested in the detailed methodology, it's published in the Journal of Public Health Dentistry this year, actually. But I'll walk you through in a nutshell what we do. What we do on the provider side is we have an agreement with CMS to give us monthly enrollment files of providers. So basically, we know the roster of dentists that have enrolled to be Medicaid or CHIP providers. We know this for every state on a monthly basis. We also include FQHC centers if they have a dentist mapped to them. And we also include dental school clinics as participating providers. And through a lot of complicated data matching through the ADA master file and a new office database, which merges in all sorts of other data as well, we're able to map 97% of locations where people can get dental care. And then we're able to light those locations up according to whether or not they have at least one dentist located there that is enrolled to be a Medicaid or CHIP provider. And again, this is based on the Insure Kids Now data in our ADA office database. Again, this has nothing to do with open chair time, accepting new patients, volume of claims, etc. Those are wonderful things. It'd be nice to have. We don't have that. But I will show you why I think this still gives some important insights. So that's the provider side. So you'll see maps where there's dots. The dots represent offices, FQHCs, or dental schools. And then they're colored according to whether or not there's at least one provider in that location that's enrolled in Medicaid or CHIP. And we're focusing only here on pediatric. So we're ignoring adults for a second. On the population side, we're able to look at ACS data at the census tract level, which are small geographies, much smaller than counties. And we're able to map the percent of the population. In this case, again, we're focusing on children. Percent of children who are on public health insurance or covered by public health insurance. Again, CHIP or Medicaid. And then we overlay road networks on top of this, and we're able to construct 5, 15, and 30-minute travel bands. We're going to use 15 minutes in the report, but we've done it for 5, 15, and 30. And then we use this fancy geomath, this two-stage floating catchment area, to basically measure the relative density of Medicaid enrolled children or publicly insured children relative to participating providers. Okay, so let's get into this. So again, I want to just be very upfront with what the Medicaid participation data tell us and do not tell us. This is a great piece that was done this January, looking at different measures of dentist participation in Medicaid. You see the quote there. My group's method is cited as the best way of basically counting heads, right? This is a head count and the most comprehensive deduped headcount of participating providers defined as you've enrolled in the program. Very important to say, we do not investigate to which these folks are actually delivering care, whether they're offering convenient appointment times. This is all stuff that we do, as you'll see, in what we call version 2.0, but we cannot do this routinely for all 50 states. There isn't any sort of database for that. But in states that we are working on as follow-up to the work I'm going to show you, we are able to look at some alternative measures of dentist participation. So let's start. So on the left is a map where you see census tracts are the shapes. The colors are the percent of children who are covered by public health insurance. Think of it as they're in Medicaid or CHIP. So the darker areas are higher concentrations or higher share of children who are in public health insurance, and lighter shades are lower poverty areas. Each dot represents either an FQHC, a dental office, or a dental school clinic. And if you're red, there is no provider in that location that is enrolled in Medicaid or CHIP. And if you're gray, there is at least one dentist in that location who is enrolled to be a Medicaid or CHIP provider. On the right, we basically take we call them Medicaid locations, basically the locations that are gray, where there is at least one dentist enrolled to be a provider. And this orange cloud cover is basically, it's 15-minute travel times around those offices. So basically, if you live underneath this orange cloud cover, you live in an area where there is at least one Medicaid or CHIP enrolled dentist within 15 minutes of you. If you are not underneath this gold cloud cover, you do not have a Medicaid or CHIP enrolled dentist within 15 minutes of you. So we're going to do some math now and run you through some statistics. The first thing we're going to do, very basic statistic, what percent of publicly insured children are underneath that gold cloud cover, i.e. what percent live within 15 minutes of a Medicaid or CHIP dentist? That number is 96. That's interesting, but not that insightful, right? If you have 5,000 children living within 15 minutes of one dentist, that's different than 500 children living within 15 minutes of one dentist. So we're going to do some relative density plots here. And you'll see we've divided Texas into 4 zones, okay? If you're in the gray zone, you're part of the 4% of children. If you live in the gray zones, that's where 4% of the children live who are publicly insured, but do not have a single Medicaid or CHIP dentist within a 15-minute travel time. Okay, the rest of the 96% who do have at least one Medicaid or CHIP dentist within 15 minutes, they break into the green, yellow, and red zones. Okay, and basically, if you're in a green zone, it means you can think of a relative high supply of Medicaid or CHIP dentists per every Medicaid child, 500 to 1. So basically 56% of publicly insured children live in areas with more than one Medicaid or CHIP dentist within a 15-minute travel time for every 500 publicly insured children. Okay. If you go to the red zones, that's kind of a relative low supply. So there is at least one Medicaid or CHIP dentist in those red zones within 15 minutes of a Medicaid or CHIP child, but there aren't many. In other words, there is less than one Medicaid or CHIP dentist within a 15-minute travel time for each 2,000 publicly insured children. And then the yellow areas are the areas in between. I want to be very clear, these numbers come from, frankly, there's no scientific basis for these cutoffs. HPSA uses 2001. We scanned all the state managed care agreements we could find to look at provider network adequacy. We found some states using a 500 to 1 cutoff. We found others using a 2,000 to 1. I'm sorry, HPSA uses 5,000 to 1. This is the Medicaid population. We found some using a 2,000 to 1. We don't make any normative judgments on what's right, what's adequate, what's a shortage. The whole point is we don't have any good science behind this. So we're very transparent. We say if you're interested in a 500 to 1 cutoff, then you're interested in the green zones as your cutoff. If you're comfortable with the 2,000 to 1 cutoff, then you could look at gray, green, and yellow zones. So let's take that. So for example, if we think we need at least 1 dentist for every 500 publicly insured children, we would infer from this plot that 56% of publicly insured children in Texas have quote-unquote adequate geographic access, meaning that there is quote-unquote enough dentists per Medicaid child within 15 minutes. Again, if you choose the 500 to 1 cutoff, and we would infer 44% live in quote-unquote shortage areas. If you think 2,000 to 1 is the cutoff that you want to use, that some states do in their managed care contracts, you would infer something different. You would say 56 plus 35, which gives us what, 91? We would say 91% of publicly insured children have quote-unquote adequate geographic access to Medicaid dentists, and 9% do not. We don't have any stance on this. As you'll see in a sec, I'll show you here. We basically put together a 1-page summary with hyperlinks to methods if you want. 1-page summary with all these data. So there's the 91% I mentioned. There's the 96%. Actually, I'll walk through that in a bit more detail because it's important. Okay, so when we look at Texas, this is just a 2,000 to 1 cutoff plot, just for illustrative purposes. You can see where Texas ranks here. I mean, it's not the highest state in terms of geographic access by these measures. It's above average. We also do this for the population as a whole. I'll skip this in the interest of time, but here we take different cutoffs, same methodology, and you can compare how access is geographically for the entire population. So again, here are a couple things, right? The measure I gave for 500, again, that's this chart here. It gives you the whole breakdown of green, yellow, red with these cutoffs. Here's the 96 statistic, if you're interested in just how many live within 15 minutes. Again, doesn't control for the relative density. And here's that 91, which is quoting the 2,000 to 1 cutoff. So you get a lot of information in this one sheet. And again, there's a lot of methodology behind this, but we were interested in just presenting something very, very policy friendly and very easy to interpret. I want to be clear about limitations. What we're doing is we are measuring geographic proximity of Medicaid and CHIP providers, Medicaid beneficiaries, to general and pediatric dentists who are enrolled as Medicaid or CHIP providers. This is for Medicaid and CHIP children and the total population as a whole. We do not do this for Medicaid adults or adults separately as a whole, purely for data constraints. Analysis does not capture the extent to which participating providers are accepting new patients or offering convenient appointment times. If that's of interest, that's doable, but I'll show you how. It's not easily done and routinely done for all 50 states, hence we couldn't do it. And analysis does not capture extent to which Medicaid and CHIP beneficiaries know where to find participating providers who are in convenient locations and offer convenient appointment times. So it's important, like, you know, you could think of redoing this analysis if you knew which dentists were accepting new patients, right? That would give you another open capacity measure. We included those that are accepting and not accepting. We don't know which share. But the point is, for the questions we wanted to answer, we did not want to exclude the dentist population that was currently seeing patients but not seeing new patients. We didn't have a basis to exclude them because we wanted to look at the active supply of people. Let's skip this. Okay, so now let me get into what we can do, or not what we can do, what you can do if you're interested in more deep dives. A way to vet some of these data is through a mystery shopper analysis. That's one analysis, which is really good. I'm showing you the data here for Connecticut. So basically, what this study does is it has researchers phone up participating providers, and they pretend they're patients, and this is done in very scientific ways, mimicking accents and stuff like that. And you can actually see if the providers are willing to take you. So in the study they did in Connecticut, 92% of the enrolled providers were accepting new patients, the vast majority which were giving appointments within 6 days. That's what this study shows here. Again, results could be very different in very different states, but this is the stuff that we've seen that's publicly available. Another way is to survey beneficiaries and ask them, well, if you didn't go to the dentist, why not? And that was a really great study done out of California, which is a good example. That's why I'm showing it. This looked at Medi-Cal families, and it focused for this exhibit only on children more than 1 year old. And it asked if you did not visit the dentist, what were the main reasons? So this kind of also is this is really important information, right? This tells you, you know, things like this is not a priority. Parent thought child was too young. Child or patient fear. Wait too long for appointment. Okay, so number 4 is the first reason we see finally that's kind of related to supply, right? Dentist says child too young. Absolutely baffled me that this would be number 6, but it is pretty high. Don't know where to go. I take care of my child's teeth. Transportation problems. Don't know where to go. Transportation. Can't take time off work. All those are navigation issues, etc. But anyway, this is the kind of research that when we do follow-up work, deep dives with states, that we basically recommend, and we are actually working with a couple states to do similar analyses like this. Because they really offer important insights. Before skipping to this, let me show you, just so you all know, if you are interested, we recently updated all of our data on Medicaid reimbursement for child dental services. If you recall, or maybe if you don't, we create a weighted average index, complicated, think of it as like the CPI. We come up with a measure of Medicaid reimbursement for child dental services relative to typical dentist fees charged, which is the left chart, as well as typical payments from private dental insurance plans in the state. So we have 2 metrics that measure how much Medicaid pays, basically. We divide them in fee-for-service versus managed care states. So obviously the managed care state data are less reliable because we are simply taking the published Medicaid fee-for-service guide. And technically, yes, managed care is supposed to use that as a guide, but we know in practice that doesn't happen. So we're certainly more comfortable with the data in red versus the data in teal. But anyway, you see here, Texas is one of the higher paying states. The reason why I put this up is because it's important, right? If you look at the Californias, Wisconsins, and Washingtons of the world, these states here, they're you know, down here too on the managed care side. These states pay really low, and I would expect that because of that, a significant share of the providers who are enrolled are probably limiting volume. So again, this just gives us a little bit more information on meaningful participation. But this is the real gold mine. When you start getting into data like the mystery shopper, the beneficiary survey, this really tells you whether supply issues are a constraint. Our data shed a little bit of light on that. It's looking at where do the Medicaid children locate relative to the Medicaid enrolled providers. So are there providers there, and are they enrolled in the insurance program? Those are 2 big pieces of information. To complete the story, you need to know, are they accepting new patients? Are they offering convenient appointment times? And do the patients know where these folks are located? That's another thing. But again, we help answer some interventions. So let me end by just walking through why these data we feel are useful and why we've gotten so much interest from the policymakers. So here's a huge area of gray, meaning there are 0 Medicaid providers in these areas. And when we go over here, we actually see that there are actually dental practices. They're just red, meaning they are not enrolled to be Medicaid providers. So if depending on who's running the program, if you are interested in making these gray zones green or yellow, let's say, one intervention is to pump more supply or to look at alternative workforce models and to do selective loan repayment, try to recruit more providers to those locations, but you still got to get them participating in Medicaid. An alternative intervention is to do something for these at least 4, because sometimes they overlap. There are at least 4 sites here that are no in terms of Medicaid or CHIP. I don't know this area whether it's high poverty. Certainly here there's medium poverty. But anyway, this lets you hone in your interventions, right? Here's another area that's gray. Let's call this area 2, area 1. Gray area 2, different intervention. We don't have any providers there, period. Now, we do seem to have poverty, right? These are darker shades. Actually, I've kind of, okay, we do have some, but let's say this smaller area here. You do have areas where there's no dentist, period. So maybe there you want to recruit new providers or do something different or do mobile services or do virtual dental home. It's not like you have a bunch of red dots there that you can convert to gray dots. And then same thing here, right? Here's a gray area, very, very high poverty, really dark, no supply at all. So again, do you want to recruit? Do you want to maybe engage these gray dots into mobile services? Maybe not, outreach. But the point is, jumping over the data limitations for a sec, this is a really, really powerful tool in our view for policy. You can actually divide your state into different intervention areas. Okay, I want to just end by saying this is our plan for follow-up work. We have a 2.0 version. We're working with 3 states right now with their Medicaid department to actually go look into claims data and to do these mystery shoppers and potentially this beneficiary survey. Basically, we also want to look at, I've showed you maps of where the poor children live, where low-income children live. But ideally, it'd be cool to say, well, actually, let's go back, right? This is important, hopefully something, right? Look at these green zones here. Let's look at a couple green zones, right? What I really want to know is what's dental care use like in these green zones? Because the data certainly suggests there's a lot, quote unquote, of Medicaid supply providers in close proximity, right? So if these green zones in the state, here's more of them, right? If the green zones have really kind of lower than average dental care use, or let's say some of them have lower than average dental care use, I may want to look at vetting those providers in terms of are they truly participating, but I also may want to look at navigation services, right? Let's say this green zone is an area of really low dental care use. Maybe I want to say, okay, how do I engage the beneficiaries? How do I nudge them, right? How do I make navigation services? How do I ease transportation? Maybe convenience is an issue. My point is I wouldn't be pumping a lot more supply into the green zones. You have your hands full in terms of addressing these gray zones when it comes to that. Okay, so that's kind of the deep dive work we're working on now with several states. And I'm going to actually end there and open it up for questions. All these data are on our website, most of them actually. The maps certainly are. But I'm actually going to hand it over to you now, David and Annalise, because I know you've been queuing up the questions. So again, this is an important advancement in the shortage debate, in our view. I've never been happy with how HPSA looks at this. Neither is GAO and other people much smarter than me. So instead of complaining, we wanted to come up with something that at least advances the debate. It's not the final answer, but we're working to get it there. So thank you.
Thank you so much, Dr. Grujesic. That was a really wonderful presentation, and we appreciate you sharing the data with us. So we do have several questions, and I'll go ahead and read them out. The first question is, how much of the growth and the percentage of Medicaid children with a dental visit can be attributed to the increase in dental capacity in community health centers?
It's a great question, and I don't have an answer. So we do know nationally that FQHCs, and I don't remember exactly the year, but we published this. We do know that the safety net facilities, FQHCs, have disproportionately driven the increase in dental care use, or I think it's over the last decade. In Texas, I don't know if that's the case. So we're not able to look at where the visit happened in the CMS data. So we can't answer that one.
Okay. The next question, in comparisons of US and Texas dental visits in the past year, are eligibility periods comparable?
For US and Texas, yes. Over time, I think that's one of the things CMS has changed. And let me just go back if you bear with me here. So the US versus Texas in every year is the same methodology. I do believe here something happened with either 90-day or 365-day enrollment. I should know. I don't. My team member who knows this is not with me. So I think they changed some way of measuring in 2010, but Texas versus US is comparable in every year.
Okay. The next question, is there data that shows differences in reimbursement rates and utilization rates?
I guess the relationship, right? I mean, do higher reimbursement states, all else equal, have higher utilization? So if you were to do a simple plot, you'd get a lot of noise, but that's kind of not the way to do that kind of research. There is pretty compelling evidence that reimbursement increases do translate into, number one, more dentists participating, and higher dental care use, and lower unmet needs. I mean, that's research we've done in a couple journal papers, Sandy Decker's done, Tom Buckmuller, others. But I think the real question for policymakers is that the most efficient use of resources, right? So we know a lot of things could potentially increase dental care use. I think the challenge is we haven't really synthesized the evidence to look at the cost benefits of each of these interventions. But to answer the question, yes, there is pretty solid research that reimbursement rate increases do translate into higher dental care use. I mean, Texas is kind of the classic case for that, right? I mean, you went through the whole lawsuit and reimbursement increase period, and that's driven part of these increases.
Okay. So there's a question about travel time and whether or not that distance is a true 15 minutes of travel time, I guess considering other factors like traffic, etc.
So, yes, it is. So it depends what we mean by true. It is based on road networks, right? So it's not bus networks, for example. So that's one thing to keep in mind, because we get questions a lot of time, well, what if you don't have a car, right? So it's different. The whole thing of whether it's rush hour versus traffic free, you know, that is a good question. Again, I don't have my lead staff who led this analysis. He would know, but I will get back to David and Annalise on this. Whether it's some average, let's say, speed limit given traffic, or whether it's the posted speed limit, I'm not sure.
Okay. And the same person mentioned, following up on your comment, I have access to Medicaid claims data for all the U.S. and the median number of Medicaid children per provider for preventive dental care is about 257 in Texas, but 71 in Wisconsin.
Okay, not sure what. So read that again. It's the number of.
It was in relation to one of the maps. There's another follow-up comment that I can also provide to you offline, Dr. Bujasek.
Sure, it'd be helpful, yeah.
Okay. Texas seems like an anomaly when it comes to Medicaid providers and dental care usage for kids. What is Texas doing differently from other states?
So I don't know, David, can you help me out on this one?
Sure.
I don't know enough about that.
So you know, a lot of the change in access is directly related to the FRU lawsuit. So Texas is currently under a court decree to improve access to Medicaid. The state was sued by an individual. This was probably now about 20 years ago. And it went through the court system over many, many years. But she wasn't able to, she had Medicaid benefits for her child and was unable to access dental services. None of the dentists in her area at that time accepted Medicaid. So the state was under a court decree to improve access to care and for children with Medicaid. And so one of what they did in response to that was to increase reimbursement rates and some other initiatives that have improved access to care for children. And I think that's showing in your data, Dr. Bujasek.
Okay, thanks.
So the next question, the U.S. Department of Health and Human Services released a report in February 2015 titled National and State Level Projections of Dentists and Dental Hygienists in the U.S. I'm not sure where the question, maybe that's just general knowledge. There is another question comment. Can you get the data to do a deeper dive for your own area? So this comment comes from someone in Texas who wants to know how to get a deeper dive in the geographic area that they're in.
Yeah, so we get this a lot. So basically the nice thing is that this analysis is, like a better term, zoomable. So the infographics are state level summaries. You can get in touch with me here at the email on the screen, and if it's not too much work, we'll just do it. If it's a longer engagement, we could talk about collaborating on something.
Okay. So I think from that initial comment about the Health and Human Services report, the question was, which was in a different section, so I apologize. They projected a shortage of dentists in 2025 in that 2015 report, but HPI projects an increase in supply. Is there just a different methodology between the two? Or are you using different data, or have things simply changed drastically since 2015?
So it's mostly different methodology. So we are projecting the supply side. We're not making any judgments on shortage surplus, right? Because to do that, you'd have to overlay demand. And to overlay it even at a statewide level is, to me, pretty uninformative. Because, you know, you can think of increasing the supply in a state in rural areas versus urban areas. That's going to be a different impact, right? But long story short, and we don't have enough time for this, to me, that HHS methodology is highly flawed based on the assumptions it makes on the supply side as well as the demand side. I mean, we're seeing an era of steady decreasing dental care use among adults in the U.S. Their demand projection doesn't take account of that, right? And that's not a critique, it's just that they're looking at this, I think, maybe more of a needs-based, based on population growth and stuff, whereas an economist will look at it more on a demand-based. But in a nutshell, it's different methods and different assumptions.
Okay, so we're going to choose one more question. It is 1 p.m., but I wanted to throw one more question at you, Dr. Bujasek. Does utilization data in Texas differentiate between dental services provided in a dental office versus a medical office?
The question is, the visits that happen in a medical office, are they counted as visits in the CMS 416? I am not 100% sure, but I do believe they should be. But don't quote me. I don't know if others. David, do you know this one or no?
I don't.
Okay. So, yeah, put me at 80% sure on that one.
Okay. Well, Dr. Gujicic, there are more comments and questions, and what I will try to do is compile them and send them your way. Or if we were not able to get to your question or comment today, please feel free to reach out to Dr. Gujicic via the contact information on your screen. And we just want to thank you again for taking the time to present your data today and answer our questions.
My pleasure. Thank you for having me as always.
Thank you everyone for attending.